Thanks, Manuel. So I'm going to keep my camera off as well during the presentation. I seem to be having some connectivity issues here today in Nova Scotia. So I don't know if it's the far stretching band of humidity that seems to be across the entire country, because yes, it's even hot and humid in Nova Scotia, which doesn't often happen for us. But right now we're sitting at about 38 to 40, I think, with our humidex. So I think that's fairly consistent right now. And so we would like to thank the CDTRP for this opportunity to come and talk about our experiences with both our operational and our research-based approaches to some new legislative and system reforms in the province of Nova Scotia. Jade and I are here on behalf of the LEADDR Research Consortium, and you'll hear a little bit more about what that is and who we are. But at the bottom of the screen, you will see who the 5 partner organizations are. So Nova Scotia Health, the CDTRP, the Department of Health in Nova Scotia, which is the Ministry of Health in the province of Nova Scotia, Canadian Blood Services, and Transplant Quebec. And so we're very excited to be here and to share a little bit about what we've been doing over the last few years. As I've mentioned, we're going to give you a little bit of background context about Nova Scotia, why we're here talking today about not only what's happened in Nova Scotia, but what led to the decisions around legislative and system reform for deceased donation in Nova Scotia. And then we're going to share a little bit about how we've been approaching knowledge translation and knowledge synthesis, both in our research academic framework, but also in our operational framework. So in case you weren't sure, Nova Scotia is sort of at the far east side of Canada. We're the little red spot there on the screen. We're one of the most far east provinces, with the exception of Newfoundland. We have a very modest population for a small geographical area. So we're just shy of 1 million individuals for the entire province. Nova Scotia provides tertiary and quaternary healthcare services for all of Nova Scotia and much of the maritime provinces, but we also provide transplantation services to all of Atlantic Canada. So the difference between the Maritimes and Atlantic Canada is the Newfoundland and Labrador piece. So if it's maritime provinces, that's Nova Scotia, New Brunswick, and Prince Edward Island. And if it's Atlantic provinces, it's those 3 provinces plus Newfoundland and Labrador. And so certainly there are patients in Atlantic Canada that also go to Quebec and Ontario for different organ transplantation services. Primary abdominal organs are done here in Nova Scotia for that region. From a deceased organ donation perspective, we've given you a bit of a snapshot over the last 8 years in deceased donation in Nova Scotia. And as you can see on the screen, relative rates of deceased donation were stagnant for a number of years. And then we had a little bit of a dip here in 2017. And in 2017, our deceased organ donation program did start having conversations with our executive to talk about system reform. And then in 2018, we were approached by our premier at the time to talk about deemed consent or presumed consent. And I'll talk about that in a few more slides. As you can see, that as information sharing and decision making around new legislation and new system reforms occurred in the academic or calendar year, pardon me, of 2020, we did see probably one of the best years, well, not probably, the best year in deceased organ donation history in the province of Nova Scotia. And we're still doing an analysis of the impacts and what was the driving factors behind that increase in deceased donation. But certainly we know that public awareness was one of the big drivers there. As we started in 2017, really trying to examine what are some of the key factors that we wanted to look at from a systems level perspective, we started examining the literature. And in 2020, Canadian Blood Services did produce material that really highlights the high performing and key areas are key elements for high-performing deceased donation programs. And so these are sort of parceled out into the 6 areas that you see on the screen, but you really have to focus on different areas or different elements to determine what is it that you need when you're looking at your own deceased donation environment. And as we were starting to examine our deceased donation environment, we were really focusing on resources and infrastructure, leading practices, system performance, data and quality improvement, and legislation. So we really focused on 1, 2, 4, and 5 as we were starting to examine what was happening within our own province in Nova Scotia. There's so many foundational elements that are important and key in increasing deceased donation for a system. And so the material that Canadian Blood Services has put out has a really good, sound starting board for any programs that are looking at doing a quality improvement analysis of their own system. Myself and 2 of my colleagues, Dr. Krimpatic and Dr. Bede, we have sort of detailed the process that we undertook in Nova Scotia on behalf of our colleagues, some of the examinations that we had put in place, and some of the material that we had discussed with our Premier and our executive at the time, and why we in Nova Scotia were ready for both system reform and legislative reform. And so we really wanted to highlight some of the key areas for needed improvement in our system, particularly because historically Nova Scotia, although a small population-based environment, did have some of the higher donor per million rates in the country for many years. And then, as I had mentioned, in 2017, we did have a substantial decline in that year. And we started examining sort of those key elements that were published, and also trying to determine how we could improve the system overall. Coupled with antiquated legislation that existed in this province since 1989, and then an opportunity, as I mentioned, in 2018, where we had a government that was very engaged in seeing improvements in deceased donation and transplantation in the province, we were ripe for moving forward. And so there was a number of different areas, particularly from a legislative reform perspective, that we moved towards with our colleagues in government, one of which was really focusing on the concept of mandatory referral of all potential donors. So there certainly are provinces across Canada that have legislation that includes mandatory referral or required referral. There's other provinces who have a policy-based or a hospital policy-based approach to this. And so what we determined for our province, we were better suited to have a legislative approach to this mandatory referral than a policy-based approach to this referral requirement. Something else that was very new for us was the concept of direct contact between donor families and transplant recipients. And so there's very few jurisdictions in Canada that enable direct contact between families, donor families and transplant recipients. Generally, donation is confidential and anonymous. And so this will now enable a process to exist whereby either a donor family or a transplant recipient can identify that they'd like to meet the other, and then we have a facilitated direct contact process that will begin 1 year after our legislation took effect. We had, as I mentioned, a very antiquated policy, and so we also then had very outdated approaches to substitute decision makers for either assent or consent, depending on who that individual was and if they could either register their consent to donate or be deemed consent to donate. And so that was very helpful to have updated to enable donation. And then, of course, the one that's probably had the most publicity of all, which has been what's called deemed consent or presumed consent or an opt-out consent. And essentially, these are all one and the same. They're very synonymous with each other. So presumed to have consented if you have not opted out, and hence the fact that you hear it labeled as opt-out. consent, and then we decided to adopt the language that came out of the United Kingdom, which was that you are deeming to consent if you have chosen not to opt out. And so hence the fact that you'll hear us reference it as deemed consent. When we started down this path 3 years ago, we absolutely used the language of presumed consent, but we really felt after engagement with some patient and family reps that deemed consent seemed much more appropriate for the environment that we were in. And as I mentioned, when we really started examining ourselves and talking to our government colleagues and looking at our scorecards, and again, this is material that our colleagues at Canadian Blood Services had published as a scorecard, if you will, when we look at some of those key elements, you can see that Nova Scotia did have some key elements in place, but not all key elements. Mandatory referral, as I mentioned, we decided to take down the path of a legislative reform, and then donation physicians were one of our system reforms that we really wanted to integrate into the system reform, because I think we've seen in Ontario and Quebec in particular, where there have been some substantial improvements in deceased donation, and a lot of this has been attributed to an integrated approach that includes the organ donation organization, but also frontline physicians that help translate information sharing in those healthcare facilities. One of the things I think that's incredibly important, and I would be remiss if I didn't mention this, is that if you start to investigate deemed consent or opt-out consent or presumed consent, you will see that there is a variety of opinions and literature that will support either yes, the system works well, or no, the system does not work well. There was a very important publication that came out in 2019 that really talked about there really wasn't a significant difference in deceased donation or transplantation activity between countries that look at both opt-out versus opt-in or affirmative registries, which many of our provinces also have. However, just recently, our colleagues in the United Kingdom, who have done a staggered approach in 3 countries, the UK, Great Britain, and now Scotland, most recently, did have a 3-year data that did demonstrate that over time, as you can see, that as time lapses and time goes on, the consent rate is actually greater with the deemed consent approach, and therefore more transplantations versus not having it in their countries. And so you can see those approaches over time, particularly from the Welsh perspective. And so that's sort of what's brought us as a consortium together. Is we had a number of colleagues nationally who were interested and excited and really wanted to examine the impacts of legislative and system reform from the Nova Scotia environment and perspective, but also to start trying to figure out what are some of those key elements that have made us the most successful and what has had the best impact to date in the Nova Scotia experience. And so LEADDR really is a coalition of investigators that come from a multitude of individuals with expertise in multifaceted areas. We have a lot of clinical experts in deceased donation from across Canada. We have individuals that have substantial research expertise in both donation and transplantation, but also from the lens of legal, policy, and bioethics. And we also have a very committed patient partner who is part of our steering committee and has been invaluable in providing support and direction. We also wanted to ensure from the Nova Scotia lens that the Nova Scotia Health team and the Department of Health and Wellness were both included in the steering committee and in initiatives, because from a collaborative approach to the legislative and system reforms here locally, we felt that that was incredibly important to ensure that we had knowledge sharing between and amongst our groups. And it also helped us improve our overall collaboration with ourselves, but it also helped us improve collaboration nationally between our health representatives, our Nova Scotia health representatives, and then our colleagues nationally. It is a small community that really does focus on deceased donation and transplantation, as many of you are aware. And so we really felt it was important to ensure that those linkages were developed amongst all of our stakeholders.
Great, thanks, Cynthia. So I'll just give a little more information about LEADDR, and then we can talk a little bit about change management knowledge translation. So LEADDR is funded by Health Canada through the Healthcare Policy Contribution Program and the collaborative VODTC, and it's funded from 2019 to 2022. Administratively at Nova Scotia Health, our VP of Research, Dr. Gail Tomlin Murphy, is the administrative lead. And then we have two national co-leads, so Dr. Stephen Bede, who is the medical director of Legacy of Life, and Dr. Matt Weiss, who is a pediatric intensivist with Transplant Quebec. As Cynthia was saying previously, we do have integrated expertise, and we formalize this through a 5-partner collaboration and a consortium agreement. So this includes obviously Nova Scotia Health, so not only Legacy of Life, but research and innovation as well, and the Nova Scotia Department of Health and Wellness, Transplant Quebec, CDTRP, so the reason we are able to talk to you guys today is through their partnership as well, and Canadian Blood Services. Do you mind going to the next slide? Thank you. So LEADDR is quite large in everything we're looking at. So we are split into 3 activities, and they are defining and measuring the quantitative impact of the legislative reform, co-led by Drs. Christina Krompotic and Matt Weiss. Activity 2 is understanding the experience of deemed consent elsewhere, co-led by Dr. Christy Simpson and PhD candidate Amanda Lucas. Activity 3 is understanding public and healthcare professional knowledge and attitudes, and this is co-led by Dr. Robin Urquhart and Dr. Stephen Bede. Next slide, please. So activity 1, just a little more information about what that means. So we are aligning our potential donor audit information with national recommendations. So this is so that the information we collect can be compared across the country. This also means we are converting those paper records we have in Nova Scotia into a searchable electronic database, which is super important for establishing a baseline performance prior to the implementation, so we can see where we've been to see where we're going. From there, we're also looking at the historic and estimated impact of this change, an interrupted time series so that we can look at these changes not only over time, but over geography, so comparing to a few other provinces in Canada. We want to see the impact of the registration in Nova Scotia, so the changing from opt-in to opt-out, waitlist and recipient outcomes for living kidney donors, and pretty importantly, an economic analysis using kidney donors in particular. Next slide, please. Activity 2, we want to focus on reviewing national and international donation and transplantation legislation, conducting quantitative reviews of the impact of deemed consent on donation metrics and the public opinion, as well as conducting scoping reviews of the ethical and logistic implications of deemed consent models. Next slide, please. Activity 3, we are analyzing the media response, which has been very interesting so far, and understanding the attitude and beliefs of healthcare providers and different community groups in Nova Scotia, as well as understanding the experiences of international jurisdictions. So as Cynthia alluded to, Wales already has deemed consent, as well as many other European countries. So understanding their experiences as well is super important. We are also going to analyze the implementation of the legislation and conduct a family-centered assessment. And so this brings us back to Cynthia as well. I'm still muted.
Sorry, I was talking to myself on mute, everyone. So one of the things that we really had to sort of run in parallel and really goes hand in hand, of course, with knowledge translation is also change management, because without change management initiatives, you really cannot have a strong knowledge translation and a knowledge synthesis approach to anything that we do in healthcare. And so one of the key pieces is really, what is the change? Well, I mean, I don't want to say this was sort of a no-brainer for us, but it was very obvious and evident that we had legislative reform, we had system level reforms, and we had some very specific initiatives and activities that were going to be going hand in hand with those system level changes. And so again, as Jade talked you through some of the activities that we're undertaking, we essentially looked at both the activities and the operational approach. So what were we doing with healthcare teams, with our organ donor organization, with our transplantation colleagues to get everybody prepared for this new change, and how are we going to study it? And so we really have been trying to work in parallel with each other to ensure that as we're going through all of these different measures and approaches, that we're doing this sort of step by step. So we really have to ensure that the change is clear. We need to understand and try to anticipate what are going to be the impacts to those affected. So you really have to identify key strategies and plan. And so you try to anticipate as much as you possibly can what are going to be the impacts of what it is that you're going to implement, and therefore what is the knowledge that you have to impart onto those teams in order for them to be successful. You have to have a method to measure the success or lack thereof. You also have to ensure that you have both an engagement strategy from a communications and education perspective, but also from a health and human resources perspective. And as part of that, you'll also have to look at who your team is going to be as you expand this knowledge, and then what are the improvement pieces that are involved. And we'll talk a little bit more about this, but a lot of the times in healthcare, we look at this from the model for improvement perspective, and I'll talk about that in just a minute. And then we have to really implement a support structure that helps us continue to be successful in ongoing execution and measurement for change, and also an ability to not only measure the change, but determine when the change has become stagnant, and we have to keep reassessing and reanalyzing so that we can continue to improve that change. When we layer this on together, one of the things Jade and I really tried to consider is, how do we demonstrate what the activities look like with a layer of operations over it? And so I know that we mentioned how we've integrated our colleagues at the Department of Health. We've integrated the Nova Scotia Health Authority because our organ donor organization and transplant program both sit under that umbrella. And then we also have integrated our researchers and our steering committee into conversations related to all of the activities, but also our operational approaches to care delivery as well. And so when we really started thinking about it, we really wanted to ensure that we had an academic approach in our operational framework, and vice versa. And so you can see that the way that we look at this is that our operation sort of spreads throughout all of the activities, because we know that every piece of information that comes through from activities 1 through 3 and all of the sub-projects are going to actually guide our decision-making in our operational framework. And so, you know, a lot of individuals in healthcare and healthcare improvement look at the model for improvement. You may have heard about this from what's the acronyms PDSA, Plan, Do, Study, Act. But really, if we go back to the change theory approach, it's the same concept. You have to make plans, you have to apply an approach, you have to study that approach, and then you have to action upon changes over time. And when we started teasing out the different activities, of course, there's multiple different theoretical frameworks that are guiding the work of the different research activities. Some of the ones that our teams are using are listed here on the screen. And if I just pull out the theoretical domains framework as an example, we know that theoretical domains really inform us about factors that influence behavior change. And so you can imagine for the team that's looking at activity 3, and in particularly both the public and the healthcare professionals' knowledge and attitudes piece, that's an incredibly important piece of information to share back with the operational group so that we can then apply the knowledge that's gained through that activity to our operational approaches. And so our activity 3 groups are absolutely trying to ensure that not only do they represent the masses in Nova Scotia, but more importantly, that they also represent the knowledge and attitudes of historically marginalized communities within the province and those that have limited access to socioeconomic factors. And so we really try to be very broad in our approaches and very broad in the information that we gain from this activity. And as we work through collaboration with all of the activity leads, what we really want to do is, again, take that information in. We want to adapt and apply it to our operational environment. And then we may change some of our tools and resources or even our approaches to care delivery based on that information that we gain. And as you can hear, this is a very iterative process, not very well depicted in the picture on the screen, but it very much is meant to be very cyclical, as I've described, because it really is supposed to be this continuous approach to change and knowledge translation and also knowledge synthesis. And I think that's the other important piece. Maybe this change management diagram helps us a little bit more. It is a very challenging thing to put into an image, but certainly, as you can tell, it's a very cyclical approach, and every piece doesn't run linear to how it's described, even in a cyclical pattern. Certainly what you try to do is assess information as it comes in and then tease out, is it part of an engagement, a measurement, an execution, a team-based? And so it's really thinking about it from that lens and always thinking about it from that lens. And so when we really think about knowledge translation and how that applies, I think we can all agree that, you know, knowledge translation in and of itself is very dynamic and iterative, and it talks us through this concept of sort of synthesis and dissemination and exchange and application. And again, if I go back to this concept or this concept, a lot of what we're trying to apply really does speak fully to almost that definition of knowledge translation, because what we're really trying to achieve is a system that is dynamic in nature, but also responsive and responsible. And so we really start thinking about knowledge synthesis. So knowledge synthesis, of course, is being very much derived from our experiences that fall under our different activities. So we're trying to the best of our ability to gather as much information as we possibly can through all of our research avenues so that we can start both examining how do we disseminate that information nationally, internationally, academically, through evidence-based approaches to colleagues, but also then how do we disseminate that to the front line? And as you've heard, what we're trying to do is almost, I don't want to say mirror because it implies maybe that we're duplicating or we're doing the same thing, but we really are trying to take the information that we glean from our research work and then translate it into operationally sound approaches to care delivery. And I keep saying care delivery, and obviously we don't often think about deceased donation in a care delivery framework, but certainly when we think about our teams at organ donor organizations working with both families, potential donors, and healthcare professionals, it really is a care delivery model. And so that's how we apply that in a very sort of sound and concerted way. And then the exchange and sound application, again, it really is, again, I keep envisioning this sort of cycle or gears because it is very iterative. And so we keep working together, I would say nationally, quite honestly, whether we had LEADDR or not, we were very fortunate that we had a very close-knit community. and we work together and try to bounce ideas off of each other, but also continue to try to drive each other for improvements.
And I think on this slide, if I just want to jump in for a second, I think that's kind of where right now LEADDR is developing their knowledge translation strategy so that we can have all of our partners work together. So not only having a LEADDR knowledge translation strategy as a whole, but then also understanding all of our partner communication strategies and the clinical space, as you're talking about care delivery as well, so that we have evidence-based policy in Nova Scotia.
And so we've done a lot of work, as Jade's mentioned. We're really in this sort of synthesis and dissemination, or we're almost to the dissemination phase. So again, sort of two streams running parallel to each other. The research side, we are putting together a really robust package of how we're going to translate knowledge that really often is very consistent with what I think most research-based or academic-based individuals would expect. So obviously peer review publications, opportunities such as this to come out and talk to groups that are in the same stream or realm as us, plus other national and international speaking opportunities. We're also looking at how do we engage beyond our traditional means from a group-based perspective. Of course, the other piece of it is both from the LEADDR group and from the collaborators group. There's a lot of meetings that go on with other jurisdictions, other provinces, because there has been a lot of interest in the legislation to date in Nova Scotia, as they were the first jurisdiction in North America to move forward with this type of legislation. And so I think, you know, we've had requests to meet with individuals, and this has been both from the LEADDR side and from the operation side. And other knowledge exchange events are going to be key from the LEADDR-based perspective. From a healthcare community-based perspective, we've run a sort of a communications plan that worked both internal to the health authority, which covers all of Nova Scotia with the exception of our pediatric children's hospital, who we also partner with. But we also did a public campaign that our Department of Health and Wellness was responsible for public information sharing. Much of this is, again, it's continuing, it'll be ongoing. So we're working both internally with our healthcare professionals and we're working externally with the public. Currently, we're focusing on refining the information sharing that we're doing with healthcare professionals. And so the knowledge translation that we initiated was really what is it that healthcare professionals needed tomorrow, as an example, to enable to do their job with the new legislation that came out in January of 2021. And now we're at the point where we're not only reinforcing what it is that healthcare professionals must do because of that new legislation, but also then refining what is the additional knowledge they need to support deceased donation in their care environment. And as an example, if I work in a critical care environment or an emergency department and I make a referral, whether it's mandatory, meeting the triggers or not, what is it that I have to do after I make that referral? And so we're continuing to build upon the knowledge sharing that we're doing with the clinical operations group. And then we're also focusing a lot of work with our Nova Scotia immigration team members who have very open access to individuals that are newly immigrating to Nova Scotia. And we're trying to really determine what is it that families who are new to Nova Scotia need, and in what languages do they need it, and what do they need to understand so that they feel safe and secure with not only a decision that they may make or not make, but also from a purely healthcare lens, depending on where they're coming from in the world. And so, again, we're trying to reinforce the concept of trust in the healthcare system, but also then trust and faith in opportunities for individuals should it arise for deceased donation. And that is a little insight into the journey that we're currently on in Nova Scotia. As you can tell, we're not through our journey yet. I feel like we're years away from the end of that journey. But we really thank you for inviting us to come and share our experiences to date, and give you a little bit of insight in how we've sort of taken theory and applied it through a practice lens, and how we anticipate we're going to continue to do so through the LEADDR initiative.
Fantastic. Well, thanks, Jade and Cynthia for this great presentation. I'm just going to press stop to the recording right now.